Okay.
This
Good,
conference
good.
will now be recorded.
Can you still hear us in Faduderland?
It's like, now I'm looking at it, like.
Frank's gonna get here, we're gonna be done with everything. Oh, he's across the street.
Try that thing again.
Test. And I was like, oh, look, I got 3 wrong. One of them was when I changed.
When I knew it was gonna be wrong.
Check,
but
check,
I didn't
test,
stand
test.
by it, I was like, I don't.
Isn't it supposed to like blink or change colors
Hey,
or
wait,
something?
you
Oh, there it does.
Yeah.
Vaccine was.
You guys get paid while you do that?
Vaccination was
Smoke
right.
good, bro. Smoke good.
I haven't showered in 4 days.
You're doing that. Okay. The other
She's like, our
one,
company,
the one that I got on
they pay us
was
our regular rate.
regular hand washing
Well,
or vaccination.
It's trading rate. So it's
trading rate, but it's our
I
regular
did hand
pay.
wash.
Yeah, it's just, there's no chance for overtime.
But that was
Yeah.
It's just regular.
Yeah, I got that one right, but we just didn't get a test. When I was
Oh,
like,
no,
standard.
no.
Yeah, that's it.
Don't worry.
I didn't,
This
I
guy,
knew
what
it was
did
like, I
you do
know
last
it's
night?
standard.
You ran around
We go
like a
to
chicken.
the-
Your head
I
fell.
stand by my choice. The standard
Oh, I thought they were
wash is not like before you.
Oh,
yeah,
go to the
really?
vaccine,
Yeah.
standard
Yeah,
wash.
it's just in the shop for.
Yeah, that makes sense.
That's
That's how I had to.
They're like, Steve's gonna do all the
Like I knew.
refill.
I was like, the answer's gonna be what?
There's like 8 of them left.
So with the first drill I was running, I kept breaking it. And I called Lucas, I was like, take
And I'm all like, I'll give you my
Put the
pipes
lid
and fluids
and I'm
for
gonna
the
go
lecture on it.
124. So right back to 124.
Okay, you guys ready? I hope so.
I think we're missing.
We're missing one.
Miss one. I don't know. Go find one.
Andy,
Okay,
Big dude is.
so first tip,
There was an accident.
free tip. This one doesn't cost. How many of you changed an answer on your test?
I did.
Statistically, you were more likely to have
Right
it
the
right
first time.
the first time, and if you change it, you're more likely to be wrong.
This was the first time I didn't change the answer, but I always do it.
Like, don't get me wrong, every once in a while, there's questions on there where like you go back and you reread it and you're like, oh no, I know for a fact I got this wrong, and then you change it, right? That's one thing. But like this has been proven over and over. Like go with your gut, stick with your first answer unless like you were 200% sure you got the wrong answer, okay? It's all process of elimination. Like first kind of thing is read the question, and like if you don't immediately have the answer, if you do, great, go find it. If it's not there, that's your clue, right? If you don't have it, go through your answers, figure out what makes sense and what doesn't make sense. Usually you can narrow this down to like 50-50. 9 times out of 10, that's how those tests will go, right? Like they're going to give you 2 off the wall answers that like you can immediately just get rid of. And then they're going to give you 2 answers that are pretty similar or right, like they could be right, okay? And then from that point, you can hopefully decipher what you need to be going for. And if you have to make a guess, like it happens, right? Everybody guesses. Here's free advice number 2. When you go into a test, pick one letter, right? Like you start your test and you're like, today if I have to guess, it's going to be B. Go with B every time. Again, statistically, you're more likely to get more of them right if you stick with the same letter.
So if I answer the whole test is B.
I mean, you might shoot like 14%, but you're going to get 14% of them right.
Unless you have an educated guess, then don't just select B.
Yeah, like, right, if you're just going to like randomly select a letter, like that is your last ditch ever. Like you have no idea what this answer is. You don't know what to do with it, right? Like whatever that is for you, but stick with one letter, okay? An educated guess is better than like throwing a Hail Mary and going with B, okay? So know the answer and then go to it, right? Pick and choose, decipher your way down to it, make an educated guess, and then throw your Hail Mary, and then move on. Make sense? Okay. How many of you guys actually read this chapter? Good, okay.
I listened to it, does that count?
It'll count, yeah. So you guys, we haven't like played very much, or like I haven't taught with you guys. So just so you guys know, like I'm very big on A&P, right? Anatomy and physiology, pathophys and pharm. Like the more you know about those 4 things, you can work your way in and out of just about any problem, right? You can start at the beginning and work your way through it. You can start at the end and backtrack. You can be in the middle and put the pieces together, okay? But the more that you can know about that stuff, the easier I think it is, in my opinion, because then you don't have to just memorize, right? Like, what is right upper quadrant brain? They're like, I don't know, I got to memorize the liver and the gallbladder and this duct and this duct and this duct. But like, if you understand what all of this is and what it does and how it functions and how it goes wrong, you don't have to memorize any of it because you understand it. Does that make sense? Okay. So Becca and Chaz told me you guys are very like hands-on, and they do awesome things, right? Like making lungs out of Cheeto boxes. Like I'm not that creative, but we're gonna play a little game and we'll see how your guys' anatomy is. So free lesson number 14 today is my middle name is Van Gogh. So I want 3 of you to take that nice dude and identify the 3 structures, the 3 main structures that are in the retroperitoneal cavity. And then the rest of you, I want you to start just picking organs and stuff that are in those applicable abdominal quadrants. Right? What's up in your left upper quadrant? What's in your right upper quadrant? What's in your right lower?
Draw 'em or just write the word?
Just write it.
Okay.
I mean, I don't want to see how you guys put your change drawing stuff.
Know your A&P, Steven?
Yeah.
No. I bombed that test. That was like the test.
That was the worst test I ever did.
So like all back here?
Yeah.
Oh, okay. That's
Yeah, so first let's start with like, what does retroperitoneal mean? Right, that term is key. So retro is behind, right? So behind the peritoneum.
Oh, okay.
Okay, there's like 3 big things that sit retroperitoneal, not necessarily in the front.
Oh, it's not in the, okay, it's all over here.
What's that? No, right, because we're talking about the high emergence, not orthopedics.
Oh.
Yeah, sorry, like, as it pertains to what we're about to talk about.
Oh,
Yeah.
anywhere.
Oh, that?
Okay. I'm like, that's what you're, yeah, that's part of it. Is it that? Yeah, it's like,
Yeah, is there anything else we need to do?
it's more
You guys have
There is.
the cycle, so
No,
where this
it
works
like,
is not
it
here
helps
goes to
break down.
that screen. That screen projects it to these
It
eyeballs.
like,
So
reduces
that
the
one goes off.
No, oh, that is like,
Project over it.
it's like, oh, it's right there, small intestine. That's it.
Also allows you to walk down, draw on that screen, and it shows up classroom wide. So every single you draw, it will be one. It's actually
I would, yeah, I would say yes.
We got quite a bit of catching up to do.
Okay, you guys got 4 minutes.
Yes and no. I mean, you got like 2, maybe 3 invoices. You
Uh,
can see that. Check the
They're all in front.
So you.
They were told to cash today.
It would be pretty early to try to work through that.
Okay. You can't just make a list. Don't focus too much on getting everything done. Just make sure you have a full work order.
Yeah, I got 3 lists. You want to show me where you're working on?
Most of the stuff I've been doing is pretty much finished except for the art checks.
It's you teaching our.
Goes like this.
What's like 40 one football field? Something like that. Oh, you know what we missed over here? Isn't the gallbladder? No, the gallbladder's attached to the liver. So we have the esophagus.
Oh, I don't remember it. That's why I was asking.
Pancreas.
2 minutes.
Yeah, it's like right in. It's part, do what, the small intestine.
What's up?
Yeah. Oh, it's the J.
Retroperitoneal.
Yeah.
I remember seeing it on the test.
In there?
I don't know where
Uh,
What main ones?
I remember really there's like 1 main.
that produces bile. That's the gallbladder. No, gallbladder just holds it for the liver. That's what.
Oh, that's right, that's right. This is the one that walking by Tesco. Let's just stomp it in.
Oh, yeah. But there's.
1 minute.
But we only have 1 minute.
Are you sure?
Better than no answer. Better than no answer.
Yes, that
The spleen, stores blood.
Okay, time. All right, what do you guys come up with? Let's start over here. 'Cause this is not very nice.
Way nicer.
So, kidney. Yeah, you guys can sit down.
Oh,
Sit, stand, do whatever you
Okay,
got.
like, it's like, do whatever you like do, but get away from me.
More over here than over there.
Okay, so first of all, what is peritoneum?
Organ center.
Yeah, it's like, it's a lining, right? So like you have linings that cover the inside of your cavity, and then they also cover your organs, right?
Right.
You have like parietal peritoneum, that's what covers like the body cavity lining. And then you have like visceral peritoneum, which is what covers your organ. Okay. Now, what a lot of people don't understand about this is like, this is actually just a double folded membrane. It's not like two separate things. They're connected, okay? So it starts out lining your cavity, and then basically it'll just fold back on itself and fold. So it's like one confused kind of membrane, okay? So retroperitoneal, right? Behind the peritoneum. So kidneys, good. You guys are shooting 33%. What sits on top of your kidneys? Liver.
The adrenal glands.
Adrenal glands. So your adrenal glands.
What
Okay.
about the pancreas?
Yes.
Pancreas. Yep.
Where was that when we were out there?
Right here.
I cheated.
What is the
Talking.
gigantic blood vessel that gives me blood everywhere? Aorta. Okay. Aorta is predominantly retroperitoneal. What's the giant blood vessel that brings it all back? Vena cava. Okay.
Yeah.
It was.
Sure. How do my kidneys get urine down to my bladder?
Ureters.
Your ureters.
I just said.
So predominantly, this is it, right? Like your renal system, 2/3 of your renal system. So your kidneys, your ureters, your bladder sits within the peritoneal cavity. Your major vasculature and all of their branches predominantly are going to be retroperitoneal. The adrenal glands are kind of, like some people care about them, some people don't. And then your pancreas, okay? These are the main ones, okay? Now, what did you guys come up with over here for fat bang go?
A lot.
We've got the gallbladder behind the liver, the pancreas kind of in both quadrants, it's close to the spine, but predominantly in the upper left, if I recall, but it kind of sits in the middle, based on the book. Kidneys, appendix, ovaries, uterus.
Who was kind enough to
A
write?
penis.
That was me.
It should be there.
Actually, I think anatomically, because his belly's so big, it should be smaller.
Okay.
Also,
so
we forgot the prostate
Oh, we did
Kidneys,
and the testes.
Or no, because that one.
kidney,
Kidney.
kidneys, pancreas, epigastric, okay? Liver, gallbladder, right upper quadrant, maybe a little epigastric, right? Because that gallbladder kind of sits like halfway through your liver, okay? I think that's duodenum. Okay. So basically, your small intestine and your large intestines, like, take up all of it, right?
Yeah.
If you guys think about this, like your small intestines,
That's why there's this ziggy scribble next to it.
and then the
Goes
big
back
one
and
that
forth.
circles.
gotcha, okay. And then large intestine is gonna come up, cross over, come down, down to the booty hole.
Oh, I got it the wrong direction.
Okay. Ovaries, good, both sides, uterus, good.
Oh, this one.
And then somebody said they forgot
The testicles
Testes.
and the prostate.
prostate. Okay, prostate is the big one. So it sounds kind of stupid, right? But like, think about this, okay? We're living in a day and an age, whether you agree or disagree is irrelevant, but people are having surgeries and changing who they are, right? So if I go and transition and become Michelle, do I still have a prostate?
Yes.
Yes, right? So even if I tell you like, hey, I've transitioned and I'm Michelle now, like, you need to keep in mind, I still have a prostate, right? Does that make sense? And vice versa, right? If you were to go transition, like, do you keep your ovaries?
Probably.
No,
No.
not usually, right? Sometimes, but not often. Usually, like when females transition, they tend to lose it all. They'll get rid of ovaries, like they'll do a complete hysterectomy, right? So ovaries, uterus, like again, not 100%, right? Like ask and make sure, but typically they will lose them. Okay, so you don't have to worry about that stuff when it comes to abdominal pain. But vice versa, like I could still very well have prostatitis as a transitioned female or whatever the proper terminology is. Does that make sense? Is that why I'm Michelle?
No, it's not what it is.
It could be.
Because the prostate, is it produces the semen?
Uh,
The fluid?
Yeah, it produces
and
like the
it
fluidy
needs
part
to
of it.
go somewhere.
Yeah, it takes a whole new meaning to, no, I don't know, blue marker. Okay.
Hell yeah.
I didn't say it.
You're off.
Okay, so the objectives here, we're going to identify different quadrants in which organs correlate, which you guys just did. Consider your different field impressions of certain patient presentations, review A&P, okay? So doing medical stuff like this requires you to be a detective, okay? Trauma is easy, right? Like the bone's either broke or it's not, maybe I'm not sure, or it's really broken, you know for sure, or they've got a giant gaping hole in them, right? You patch the hole. Like if they run out of the red stuff, game over, right? Like for the most part, trauma is fairly simple, okay? Medical stuff can get pretty tricky. Like it requires you to have a good differential, do a good assessment, do good history taking, play detective. And kind of what I like to tell people, right, is like when you go on medicals and really just anything, right, like cast a wide differential, cast a wide net, right? Don't limit yourself to this tiny little net because you're going to miss things, right? Cast a wide net and then start ruling in and ruling out stuff based on what you ask them and what they tell you, okay? Abdominal pain is like one of the trickier ones, right? Like it's really, really hard. Like it's hard to pinpoint down exactly what it is. Sometimes it's pretty obvious, sometimes it's not. So like, don't be upset if you're like, I don't know exactly what's going on. Chances are you probably won't. Okay, does that make sense? And then kind of like what this is talking about too, right? Like correlate to what they're telling you, right? So if I call you and I'm like, hey, my belly hurts, and it's like right up here, I don't know, right? Like it's probably not like my appendix on the left side.
Are you yellow?
Does that make sense? Right? Like correlate the anatomy and what they're telling you with what it is. Okay. Now you got to be a little bit careful, right? Because 99% of the time when you hear hooves, it's horses. It's not zebras. 1% of the time it will be a zebra. Okay. Make sense? Do you guys all like to play detective? I hope so. Okay. So we're going to do a case. You have an 18-year-old female. Her chief complaint is abdominal pain, nausea, and loss of appetite. During your secondary assessment, which comes before or after your primary? After, good. You note that she has rebound tenderness in her right lower quadrant. What does rebound tenderness mean?
Hurts on the way out.
Hurts on the way out. Okay, what does that usually indicate?
Appendicitis.
It's kind of vague, right? It indicates like peritoneal irritation. Okay. Her temperature is high and her position of comfort is the fetal position. Okay. So what is your differential? What could this be? Okay. Appendicitis,
Bowel obstruction.
maybe bowel obstruction.
I mean, it could be something with the
Could be like
Something with the
liver,
reproductive
kidney.
system.
Could be repro, right? Could be kidney, like a kidney stone if it's down that far. Could be an ectopic,
Ovarian cyst.
ovarian cyst. What's another one? Ovarian,
fibroids.
good, yeah. Something else when it twists.
Torsion.
Torsion, okay. Do you think this is likely to be like an ulcer?
No, not in the
Like
body.
that, you know.
Yeah, not that far down, right? Like maybe. Again, nothing's impossible, right? But
But it'd be more midline, right?
yeah, you would expect more like midline or like stomach pain, right? Something of that nature. Gallbladder, maybe, but not unless that thing's sitting like 12 inches lower than where it should be, and it somehow became detached from her liver.
Said left lower, right?
Right, lower.
Yeah, so can you saw what the liver did?
Maybe, but same thing. Is that thing down there?
Yeah.
No, that thing's up here,
Yeah, right?
right? Right upper. Okay, so good. So here's one tip. Any female of childbearing age, you should always have an ectopic pregnancy in your differential. Okay?
That last class too.
Yep.
Said that before we left class.
Yep. And same thing, you guys, like, don't be fooled by this. Like, you can be reasonably confident when you ask people, like, you know, I like to ask people this, right? Because it kind of, one, it puts them on the spot, but then two, like, it allows them to think about why their answer is the way it is, right? So if I ask you, is there any chance you could be pregnant? What are you going to say?
Absolutely not.
Absolutely not. How do you know that? Unless your answer is, I just took a pregnancy test and it was negative, or I don't have the required parts anymore, or I literally just finished my period today or within the last couple of days. Like, unless it's one of those three answers, I cannot 100% get rid of that diagnosis. Okay, does that make sense?
Yeah.
Okay.
But even like with the period, I would, sometimes bleeding
Yeah.
could be.
Yeah, same. Like, don't be fooled, right? Like, it's not common, but I've had a couple where they're like, yeah, like, I just had a period. Not 100%, right? Because, like, maybe they thought that was a period, and it turns out that was not a period. That was just them bleeding a little bit. Okay. So there are your quadrants. Your book has this picture. So depending on what you read, they'll break it up even further into like 9 quadrants. Just kind of depends. Stick with these for right now. So right upper, right lower, left lower. Okay. There's all the organs. So it contains many organs that provide various functions, right? Digestive, repro, endocrine, and regulatory. Okay. And then kind of remember too, you have solid organs and then you have hollow organs. Okay. And typically your hollow organs are what's helping you do digestion and that type of stuff. Solid organs, yeah, like, right, liver, kidneys, spleen, etc. Like, they're not, I mean, I don't want to say the liver's not involved in digestion, but it's not involved in digestion, right? They're involved in different processes.
Wouldn't that be like filtration?
Yeah, right. So like liver is like detoxification. It does, I mean, if you want to argue, it does some digestion because it makes your bile, right? Like, it actually makes bile. The gallbladder is just there to store it. Kidneys, right? Filtration. Spleen is kind of filtration, like for your blood cells and stuff like that. Okay, and then retroperitoneal. Okay, so this is what I was trying to discuss with you, and this is a much better picture here. So your peritoneum is just a membrane that kind of double backs and folds back onto itself. Okay, so it's going to wrap around your organs and then wrap around like the inner cavity of whatever cavity it's in. Right, so you have that in your chest with your pleural cavities. Okay, parietal, visceral, pleura, cardiac. Right, you have one. That's the membrane around your heart, like your pericardial sac, and then you're in your abdomen. Okay.
Is that kind of what gives us that positive pressure for, like, in our chest, that we would get the second chest wound? Is if that's compromised, that space you're talking about?
Yes, right. Like, by having that double folded membrane, like, that is what is part of what is creating that negative pressure. And so when you punch a hole in that thing, you lose that negative pressure. Yep. Okay. Organs of your abdomen. Most are enclosed within the parietal peritoneum. Few of them line the retroperitoneal space or extraperitoneal space. Kidneys, pancreas, part of the aorta. It's like most of your, well, I guess like half, but a lot of your aorta, your IVC, vena cava, and then all the vascular branches that come off, right? So like your splenic arteries, renal arteries, hepatic arteries, all of those. And then your bladder and part of the rectum lie inferior to your peritoneum. Those are the big blood vessels. You guys good with blood vessels, or do we need to go over that?
We go over the last 3.
Yeah.
Okay, so let's try this guy. Try this guy. Okay, so hepatic artery, like, you don't see it up here, but your liver would be up there, and it has to get blood flow, right? So your aorta, let's see if we can do this. Maybe not. How do we get to there? Let's go there, and then let's go there. Let's do aorta branches. Oh. Sure. Can you guys see that half okay? So these are all the branches that come off of your aorta. Okay, so like there's your common hepatic artery. So that's what's going to go off and feed your liver. Suprarenal arteries, okay, and then renal. So these feed your kidneys. You'll have like a splenic one that comes off right there. Feeds your spleen. Mesenteric artery, so it's going to go feed your mesentery. Then it's going to come down and split that your common iliac artery. So as your aorta splits, like right down here in your pelvis, it's going to make your iliac arteries, and then that branches to your femorals, and then down and down. Okay. And then on the top, right, here's your arch. Okay, your right coronary. Your other coronaries kind of come off like right behind the valve. And then you're going to have 3 branches, right? So you have like a brachiocephalic, which is going to make the right side. And then you're going to have your right common carotid, your left common carotid, and then it's going to make your left subclavian. Okay, so all of the blood flow that your body gets is a branch off of the aorta somewhere. Okay? Does that make sense? Okay. Where were we? Okay. So types of pain. Okay, so visceral pain is pain from your organ, right? From the viscera, right? Now the problem with your organs is like they actually don't really have a lot of nerve endings on them, and they don't have a lot of like sharp pain receptors on them. Okay, and that's why typically like organ pain, visceral pain is kind of like diffuse. It's hard to localize and pinpoint down. A lot of the times it'll just be like, oh, it's like this dull, achy pain. Okay, think about like the have you guys done the cardiovascular chapter? Part, right? Like the pain of a heart attack is like this dull crushing pain, right? That's why, because like we don't have like real sensory nerve endings that go to our organs like that, okay? So, and then a lot of the times what happens with like your visceral pain is like you will end up getting referred pain. So like your liver, gallbladder tend to refer up to your right shoulder. And that's because as those nerves come out, they will converge with other like second order neurons that also come from your arm. So by the time it gets up here to your brain and your brain interprets it, it's like, not really sure, because like that's the arm, but then that's also from this one down here. So I'm not sure. It might be both. Might be one. Okay.
So it's just like shoulder.
Yeah, like a lot of the times it'll be both. Like they're gonna complain of like right abdominal pain or whatever, but then they're also gonna be like, yeah, I don't know, it's kind of weird, my shoulder hurts too, right? But nothing's wrong with their shoulder. Like it's referred pain from that. Okay. Intermittent pain is usually a hollow organ. Persistent pain is usually a solid organ. Okay. And again, kind of think back to A&P, right? So like, what are your hollow organs doing? Like, they're contracting, right? Like they're secreting digestive juices. They're trying to push poopy down for you and pee and stuff like that, right? Like, are they contracting all the time? No, right? Like, when they need to contract, they contract, right? So I eat a meal, yeah, sure. Now I need to like squirt a little bile and digestive juice into my tummy and do the thing. And then eventually after like, I don't know, 12, 24 hours and all the absorption in my small intestine, then I kind of start pulling the water out of it, making poopy, like, okay, now I need to poop, so I need to push it down, right? It's not contracting all the time. That's why that pain tends to be colicky, right? That's where that term comes from, okay? So it'll be colicky in nature, i.e. it's going to come and go, because as they contract, it's going to hurt because they have a blockage or whatever's going on in there. And then it's going to kind of loosen up and let go, right? Because it's not contracting all the time. Okay.
So you said that persistent pain is a solid?
Usually, yeah. Like if you're having like a steady pain that like isn't coming and going, it's not like colicky or intermittent, that's usually a solid organ. That's good with this? Okay. If you guys have questions, just shout it out. Okay, parietal pain. So this usually originates from your parietal peritoneum, right? You have a lot of nerve endings there. And so that tends to be more of a sharp localizable pain, right? So this is like your pinpoint tenderness, right? Like, oh, like I can't really tell where it is. Like, nope, I know exactly where it is. It's like right down here, okay? Like that's a sharp, usually a parietal like pain. And then same thing, just remember like your rebound tenderness, like all that's really telling you is that you have parietal irritation, right? You may be able to localize it for sure, but it doesn't be like, oh, that for sure is a gallstone, right? It just tells you you have some type of peritoneal irritation. You guys good with that? Yes? Nodding? No nodding? Okay. Oh, what happened to my thing here? Okay, case number 2 is some gentleman in a blue shirt who is 62 years old and has chest pain.
Is that Laverne's sign?
Levine's, yeah. Upon OPQRST, what was R? Radiate, good. He tells you the pain is tearing in his upper abdomen / chest and radiates to his back.
It's that, the tear or whatever, right? That it's the sign of the tear in the, part of the.
Oh,
It's actually an
Aneurysm,
like
right.
aorta.
Can't look at it, something with the heart though, yeah. I can't remember what the fuck it's
One of those
called now.
things, heart, aorta, aneurysm,
Possibly be an
And
ulcer.
AA or whatever.
Ulcer.
AAA?
Oh,
No,
triple A,
it's
that's
called
what it's.
AAA, energizers,
Yeah.
double A's.
I think it's pacemakers just fucked up.
Okay.
Isn't that-
So, I mean, same thing, you guys, like cast your differential. Like, what would your differential be for this?
He's definitely having an issue.
Good?
He's saying it's anywhere from the abdomen to the, or the chest to the abdomen area.
Okay.
So he's not able to
Pain is
give you a
turning.
full, like, yeah.
Could be,
Chest,
could be. Okay, could be.
Is there anything else, or is that just the only symptoms that he has?
Yes.
So-
Okay. So, I mean, think about it, right? So he's telling you it's like, my belly and my chest. So usually that's epigastric, right? Like right here. What's right here?
Aorta,
Aorta,
stomach,
stomach,
pancreas.
pancreas, heart, right? Could be like an MI. Ulcer, right? Somebody threw an ulcer out, like,
Yeah.
could be. Okay. Tearing, like, here's a hint for your test, right? Tearing pain is like a very tall tale characteristic sign for like aneurysms, right? Aortic aneurysms. Okay. Now, same thing. It could be a lot of stuff, right? But like not usually. Like usually, if they feel like tearing pain, like, and it's not common, right? Like if somebody tells you like it feels like something is tearing, like they're probably right, right? Like, listen to your patients. Here's kind of like another thing with your differential, right? Like saying somebody's like, oh, they're just intoxicated, right? Like, oh, they just have anxiety, right? Something of this, right? Some type of dismissing like diagnosis, like that is a diagnosis of exclusion, okay? And what that means is like, you are 110% confident, you have ruled everything else out, nothing else makes sense. Like, right? Because if I have a tearing aorta, do you think I'm going to be anxious? Probably, right? Yeah, right? Like, okay, so test hint, tearing is usually characteristic for like aortic aneurysm, okay? Now, again, kind of part of playing detective, right? 62 years old. So, I mean, granted, he's not 90, but he's not like a spring chicken, right? Am I likely to have an aneurysm at 20?
No.
Not without some type of pre-existing condition, right? Like I'm not just going to suddenly develop one. Like usually there's a genetic thing there or some undiagnosed something, right?
Can you find that, or typically find that in your secondary?
Like if I knew about it, right? Like if I knew I had one for sure. Yep. Yeah, like if I knew I had one, I could tell you, right? Kind of interesting. Like most AAAs are actually found incidentally on a CT scan that's totally unrelated to an aorta. Okay. A lot of people like walk around and granted they're small, like a millimeter, maybe 2 millimeters, right? They don't even know they have them. Okay. But 62 years old, right? High risk. Most people have what past medical condition? High blood pressure, right? That is a huge risk factor for aortic aneurysms, right? So elderly, high blood pressure, tearing pain, like probably an aorta, okay? Okay, tearing pain, not common, originates in the aorta or stomach, aortic aneurysms. Retroperitoneal location of the aorta causes pain to be referred to the back. Ulcers in the stomach can also cause tearing pain. I'm actually going to deviate a little bit from this. So like, at least in practice, I have not seen a lot of people that have ulcers describe it as tearing pain. Okay. Usually they describe it as like just like this gnawing pain, like, and it'll be pretty characteristic too, right? Like it'll subside and go away after they eat something, right? Because now my stomach actually has something to digest other than my own tissue, right? And then as that food gets digested and moves through, now I have pain again.
So how do they typically describe it?
They like a gnawing pain, like just this gnawing, like it's there, it's there, it's there. I can't get it to go away. Right when I eat a meal, it tends to feel better. Yeah. AAAs, because of where these are, right? Because remember, like, and a lot of people confuse this, right? An aortic dissection and a AAA are in the aorta, but these are two different things, right? A AAA is when you have like an aneurysm, like outpouching, right? A dissection is when it's dissecting through a layer, okay? Not impossible, but not common to have a dissecting aneurysm in your abdomen. If you do, it's because it started up here and has made it all the way down. It doesn't just start here and then start dissecting, okay? Not common for that to happen. Does that make sense? Yes, okay. Yeah, like it's more of like an outpouching type aneurysm. So there's a bunch of different kinds of them, but yeah, right. Like it's a retroperitoneal vasculature, right? So that thing runs down your retroperitoneum, which is why a lot of these people will have back pain. Like they'll have belly pain too, don't get me wrong, but like it'll be back pain. A lot of the times they'll be like, I felt this pop. Like I bent over, and that's what's tricky about it sometimes too, is like they'll have some mechanical thing and you're like, oh, okay, well, that doesn't really make sense to be your aorta, but it is. Like a lot of them describe like, I felt this pop and now I have this like excruciating pain, or like they pass out, they have a syncopal event, shocky, right? Like if they truly ruptured their aneurysm, like chances are they're going to be dead before you guys even get there, right? Do you guys know how long it takes to bleed out from your aorta? Yeah, like seconds, right? Like, I mean, probably well under a minute. Yeah.
Why is it called a triple if it's just aortic aneurysm? Or is it like?
So it's an abdominal aortic aneurysm. Okay. Yep. And I think there's a picture of it in here. If not, we'll go find one. It'll make more sense. Okay. Case number 3 is a nice affluent looking gentleman in a white polo or something. He's 36 years old. Oh, this is me. With a chief complaint of left shoulder pain. I have a history of alcoholism and pancreatitis, and I am non-compliant. So what consideration should you take into account when assessing this patient? Okay, good, not bad. What's that called? That syndrome. It's Marfan syndrome. Marfan? Yep.
He has
Okay.
pancreatitis and he's non-compliant, so that right there
Had or has?
Has a history.
he has a history of alcoholism and pancreatitis, so, and he's non-compliant with his doctor's appointments.
Okay. What else could this be? Does gallbladder go to left shoulder or right shoulder?
Gallbladder.
Right shoulder.
Right.
Heart?
Yeah.
Could be heart. Right? Same thing. Like just because I'm 36 doesn't mean I can't have a heart attack.
Spleen could be left
Spleen?
shoulder.
Left shoulder?
Pancreas?
Maybe. Yep.
It could go both ways.
Pancreas? I don't know. I drink every day, so. Could this be a testicular torsion?
Yeah. No.
Probably not.
Shoulder.
Oh, no.
Right?
Shoulder.
Could this
Yeah,
be
but
my
all your
appendix?
nerves go back. No, appendix usually is down.
Probably not. Right? Could it be my liver?
That'll be right side.
Should be right side, right? But what if my liver was actually switched?
That is possible.
I did say
Yeah,
that.
not super common, right? But you could have, depends, like sometimes it's like one organ, sometimes it's all of them, right? So keep that in mind. And granted, they may not know they have it. They should, but
Like, does it just happen?
it, yeah, it's like it happens in development, like in embryo. All of their organs are
Oh,
switched.
okay.
And so like liver is no longer over here, it's over here. Spleen is no longer here, it's over here. The heart isn't rotated left, it's rotated right.
So literally all of them.
Yeah, like they can have a complete flip.
Have you seen that?
Yeah, I've seen a couple of them. Like usually it's like caught like at birth. It's like, oh, hey, look, it's totally flipped.
So are those people any less healthy than a normal person, so to speak?
No, not necessarily. Like you just need to keep it in mind, right? If they're like, hey, yeah, my left shoulder hurts, and you're like, okay, well, not the liver, and they're like, yeah, but I have this like sinus invertus thing. Like, oh, wait a minute, maybe that could be. Yeah. Okay. Referred pain. So we talked about this. Okay. So here's a nice little picture kind of demonstrating where some of that referred pain goes. So, heart, I would say that's more like the whole left side. And then same thing, you guys, like not everybody follows the book, right? Like sometimes people have chest pain and it's sharp and it hurts to breathe and it like refers over to their right arm, which makes no sense whatsoever. And they're young and you're like, no way. And it turns out, no, they're having a heart attack. Okay. Liver, gallbladder, right upper quadrant, epigastric area, usually to the right shoulder. Appendix usually is going to start diffuse. Okay, it's going to start like umbilical or diffuse, and then over time it'll localize down to the right side. Kidneys, ureters, like kidney stones and stuff like that, I would say for the most part, like anything on the sides, all the way down into your groin is fair game. Okay? And then on the back side, so gallbladder, liver, stomach, right, pancreas. Make sense?
I feel like that book needs to be putting like more stuff lower, like especially with the female system,
Mm-hmm.
like on the lower back.
Yeah, for sure. Okay, do you guys have any questions about this? Do you guys understand referred pain?
So does the spleen not have referred pain?
Okay, to like left side, left shoulder.
Spleen's hollow?
Spleen is solid.
Is it red? Is it just red blood cells or is it just blood in general that it stores?
Blood. Yeah, so like your spleen kind of just filters your blood and then it I don't want to say sequesters it, but it sequesters a little bit. So like when you go into shock, for example, your spleen can actually contract and it'll expel like up to 500, so like half a liter of blood back into your system for you until you run out.
Compensate to stop the shock, your body's trying to.
Yeah, it's just trying to compensate, right? Because like you're losing blood, so it's going to try and put some more in there. Half a liter, like up to 500 mils.
Because I thought it was like that big. There's
No, it's like, I don't know, size of your fist probably.
Not tiny.
The gallbladder.
Oh, so the gallbladder, is that really easy to rupture? Because that's just like, I saw it on the liver. It looked like it was just like almost a mucous membrane. It's not, but it looks really
No,
big.
yeah, your gallbladder's like, I don't know, size of a golf ball-ish. But same, remember like hollow organs, like not that they can't rupture, right? But like they can take some pressure and stretching, right? So harder to rupture, say a hollow organ versus a solid organ. Ugh.
That's not good.
You guys having a bad day.
That's the, what is it? For
That's
diabetes.
it's aliens versus predator is what that is.
See that
Those are
little thing,
worms.
that freaking.
Yeah.
Oh, what is it?
Actually, I think worms would be the best case scenario.
For diabetes, they give it for.
That's pretty gross. Okay.
Flop back and forth. So that goes-
Yeah, like
You
You can't look away.
The aortic vein to a vein to make it larger due to the inflow of blood, right?
like a fistula.
That's it.
Yeah, you'll never have a fistula down there.
But what is that?
It's probably just like varicose veins and
Nah.
like
That man has high blood pressure.
some fucked up liver. Yeah. Okay, appendicitis. So infection, inflammation of your appendix. Okay. Depending on what you read, your appendix is either totally useless and serves you no function, or it may serve some immune function. More often than not, what happens is like this thing just kind of gets full and packed up full of poopy, and then it inflames, and then it can burst. Okay. If it bursts, that's not a good day. So nausea and sometimes vomiting. I would say nausea, vomiting. Pain is often initially referred to the umbilical region, followed by persistent right lower quadrant pain. So they've kind of demonstrated this pretty good in the literature and in the studies, right? Like early onset appendicitis is usually pretty diffuse, like it's hard to localize. And that's why a lot of people mistake it, right? Because they have this like diffuse abdominal pain. And then over time, it starts to localize down to your right lower quadrant. Okay. Nausea, vomiting, common, fever. Sometimes you get diarrhea. More often, it's like more constipation. And then anorexia, so like quote unquote loss of appetite. Okay. If they rupture, you have a sudden severe increase in pain, and then obviously it's now releasing all of poopy and whatever else it was storing in there into your abdominal cavity. Yep. Yep. Okay, peritonitis, so irritation of the peritoneum, usually caused by some foreign material, infectious, for example, right, like bacteria, viruses, etc. It's sensitive, especially to acidic stuff. The irritation can cause involuntary contraction of abdominal muscles. They'll have abdominal pain and rigidity, okay? So a lot of the times they'll have what they call involuntary guarding. So you have voluntary guarding, which is like, I'm covering my tummy, don't touch it. And then involuntary guarding is like, I'm not covering my tummy, but every time you push on it, I'm flexing, right? And it's not me deliberately flexing my abs. It's me doing it involuntarily because it hurts and I don't want you to push on it. Does that make sense?
It's not your body's way of protecting
Yeah, it's your body's way of trying to protect it. Yep. Okay, case number 4. No picture. Your patient is a 42-year-old, which also could be me, with a chief complaint of abdominal pain. I report that the pain is worse at night while I am laying down. And I also report increased pain after eating a lot of hamburgers. What is your differential and what other systems would you assess? And that's what I ate for lunch today. Gallbladder, ulcer.
Some sort of like any other thing, because he says whenever he's laying down, and that's when all your stuff is like pushing.
Okay,
And
yep.
after eating. And that would be more pressure there too.
Okay.
So he says after eating his hamburgers, so he's had more than one, and they're probably greasier than others.
I had 3 of those things. Heartburn?
What's it's not a heart attack, but it presents with heart attack-like symptoms, but when they lay down, it goes away. What's that one?
I don't remember that's what.
Oh, starts with an A, guys.
That's it.
Starts with a P.
No? It's not angina?
So
That's it.
pericarditis.
Okay.
Okay, and it's the opposite. Usually they'll have a little bit of relief if they lean forward.
I thought angina, it goes away like whenever they're resting.
When they're, yeah, so like when they're resting, but like if somebody is like actively having chest pain, they're not going to be laying down.
Okay.
Yeah. Okay, so I heard ulcer, I heard gallbladder, I heard aorta, and then I heard heartburn. Anything else? Gallstones. Okay, gallstones, gallbladder. Anything else? Could this be my uterus?
Nope.
I don't have one. Okay, so granted it doesn't fit this picture, but 3 Fs. Okay, no disrespect to anybody. It's just what it's called. I didn't coin it. Fat, female, 40, gallbladder. Okay, so ulcer, good idea, but I just ate, right? So if I just ate and I have an ulcer, theoretically, like that pain should not be as bad as it was, because now my acid has something to actually eat through other than my stomach or my intestine. Okay. Fried fatty foods, fatty meals, right? Because as soon as I eat that big old greasy honking thing, which is probably worth it, right, my gallbladder is going to contract and shoot a bunch of bile in there because I need to break that shit down, right? Same with your pancreas, it's going to throw some stuff in there and I'm going to start trying to break this down. Does that make sense? So that's very common for like gallbladder, gallstones, cholecystitis, right? Like I just had a meal, high in fat, and like now I'm having this excruciating pain, right? Colicky comes and goes. Worse at night when I'm laying down. So you guys all kind of understand like why we go in the fetal position. You guys ever thought about that? Right? We've all done it at some point in our life, right? Like you get a bellyache and like you curl up and do this, right? Why do you do that? It feels better, right? Okay, that's because you're taking pressure off of your peritoneal cavity, right? So like if I lay down straight, like because I want to do this, and that's what takes the pressure off of that peritoneum. Okay, that's why they do that. Make sense? Yep. Okay, so there's your gallstones. So you guys took me in, I ordered one more of these for the road, and that's what they found in there. Okay, so cholecystitis is inflammation of your gallbladder. Cholelithiasis is the actual term for like gallstones when like they're stuck in your duct. So this is caused by a blockage of bile flow by the stones. Okay, severe right upper quadrant or epigastric pain, usually nausea, vomiting. Pain is often going to refer to the right shoulder. And then honestly, just kind of depends. Like the stones can be made out of a couple of different things, like calcium crystals, different salts, bile packed together, et cetera, et cetera. Sometimes you open it up and there's like this tiny little thing in there. Sometimes you open it up and it looks like that crap and they're like sitting on like 30, 40 stones. Okay. Yep.
That was you.
Did you keep one? Oh, I kept one.
Dude, my mom kept the whole thing on there.
That's
That's
badass.
disgusting.
That's
Oh, I
cool.
think it's still.
No.
You're all.
Okay.
No.
Uh,
That's gross.
GI bleeding. Okay, so this is bleeding anywhere in your GI tract, right? So basically, for all intents and purposes, right here, all the way down to where it comes out. Okay. So from your esophagus to rectum, this could be minor, it could be severe. The blood eventually exits. Yep. Often painless. Okay. Usually, unless you have like a tear. Like if you've torn your esophagus or something like that, they're going to have pain. Outside of that, they usually don't. Like they might have some vague abdominal pain, or they may have pain. If they do, it's probably related to like ulcers and stuff like that. Okay. Let's see. So what's your?
Are ulcers considered a GI bleed then because they're part of the stomach?
Yep. Yeah, like when you have an ulcer, it's gonna like it'll cause bleeding eventually, right? Usually this is broken down in between upper and lower GI bleeds, and where they define it is the ligament of Tritz. And so usually it's like right at the bottom of your stomach there. Okay. So anything below there, they consider a lower GI bleed. Anything above there is considered an upper GI bleed. Okay. 9 times out of 10 with an upper GI bleed, you're going to see black. Okay. So melena is black tarry stools. Okay. Hematochezia is the word for like bright red blood in your poop. Okay. But usually your upper GI bleeds are going to present black, right? And they're black because they've gone through your digestive system and you've partially digested it. Okay. That's why it looks black. They may puke that stuff up or it's going to come out the other end. Okay. If you're seeing bright red blood, if they puke up bright red blood, like that's probably a pretty active, brisk bleed, especially if it's a lot of it, right? If they like puke up a little bit and there's like a tiny little bit of blood in there, like, yeah, okay. If you see bright red blood from the, like in your stool, like from your rectum, those are usually non-life threatening. That's usually like a polyp, a hemorrhoid, a small tear, something like that, maybe a malignancy, right? Something like that. If you're seeing a lot of bright red blood coming out of your rectum, that can be one of two things, like either really, really bad lower GI bleed, or you have a really bad upper GI bleed, not the middle finger, but like a really bad upper GI bleed, okay? And that's because it's bleeding so fast, you don't have time to digest it. Does that make sense? Okay.
In the far right picture. Blood.
Wait,
Well,
in the toilet?
Yeah, but it's like, it looks like tissue.
yeah, it's like half clotted.
Oh, that's, okay.
Yep. First time you guys ever smell this, you'll never forget it. And you'll walk into someone's house and you won't have to look in the toilet. Okay, AAA, so a ballooning or weakening of the inner wall of the aorta tears and separates from the outer layers. The weakened vessel will bulge, it can continue to grow, it could rupture. There are the signs and symptoms, usually progressive sharp or tearing pain or pan. It'll radiate to their back. If it truly ruptures like all the way through, it's going to be like excruciating pain and then like signs of shock and they're going to be dying. Okay. So this is kind of what we were talking about earlier. So actually kind of a bad picture. So is that your abdominal aorta or your thoracic? Thoracic, right? Because your abdominal doesn't have an arch in it or 3 branches that come off the tongue, right? So you tend to dissect in your thoracic aorta, not your abdominal aorta, okay? Your abdominal aorta is going to look more like that. Okay, it's just going to like bulge. So usually with like an abdominal aorta, there's a couple of different ones you can have, but usually it goes through the first layer and then it'll just kind of balloon out. Okay, but it can rupture, but it'll just balloon if it hasn't ruptured, and then it'll keep ballooning, or it's actually going to just kind of clot itself off. Okay. Your thoracic. So usually what happens is you get a tear in that innermost lining. And then again, like think about this, right? This is why this happens this way. So where is the pressure greatest in my aorta? Is it at the thoracic or my abdominal? Thoracic, right? Like right after that thing comes out of my ventricle, right? So the pressure is highest here. So it's going to rip through that first inner layer, and then that pressure is going to keep it pushing through. And so you're going to separate it out like a layer of an onion, okay? Yep. And these, I mean, not like common all the time, but also like I've seen this a handful of times, right? Like they can dissect from the beginning all the way through down to their iliac artery, down into a femoral, right? Like your coronaries come off of here, so you can dissect down a coronary and like it'll look like they're having a heart attack. If they dissect up into a carotid, they're going to look like they're having a stroke.
So JVD, okay. Would you see JVD with that? Because it would be
no, not necessarily.
Right, it would be smaller. No.
Well, remember, like what is JVD from? Like, why do I get JVD? Backup, right? So I don't necessarily have backup, and my heart isn't being obstructed of pumping.
Right, but it would be ballooning, so wouldn't it appear to be JVD, but not?
No, because it's inside your chest.
Right, because this is inside your chest. Like, you're not going to see
No,
it.
but if it goes up to your carotid.
Like, if they have dissected enough to where you see a bulge in their neck, like, they're probably toast.
They're dead already.
Yeah, like this is not something you're going to, like, see. This is something you're only going to see on, like, CAT scans.
No, it makes sense why. Right, it would have to do almost like a back switch just based on like.
So that thing down there that's kind of hidden, that's unequal pulses or blood pressure. So in your dissecting aneurysms, you're looking at pulses and blood pressures in the arms. Okay, you may find unequal pulses or different blood pressures, but not all the time. For your abdomen, you may find like unequal pulses in your legs. Make sense? You guys good with that?
And for the AAA, whenever you're like palpating the abdomen, can you feel it sometimes? You have pulse of the balloon?
So they say that like you won't feel this unless it's like 5 centimeters or more. And I mean, don't get me wrong, like I've seen a couple of them, but like if you can feel it, like that thing is huge. And if you do feel it and you're like, oh, I think that's a AAA, like don't touch it. Okay. But you can, like if it's big enough, yeah, you can feel it. You'll feel like a bulge. It'll be pulsating, right? Because it's a blood vessel. Okay. Case number 5, a 20-year-old, not me, that called EMS from the gym. He does a lot of heavy lifting and now he has a bump on his belly. And apparently he ignored it until the day, and then it started changing colors. And I used to be able to push it back in, but now I can't. Hernia, right? Oh, and apparently that's what it looks like. He's got an Audi.
Hell yeah.
Okay. So hernias. Okay. Hernias are not uncommon. Little uncommon in younger people, but not uncommon. It just kind of depends. It's a rip through the abdominal musculature, and then you get an organ. Usually it's an intestine. Okay. You can have them in your belly, umbilical, like inguinal, like down in your groins. For males, sometimes like they can push them down into their scrotum. Okay.
Isn't that because there's like a small hole where the intestines can fall?
Yeah, right. So like there's going to be a hole like in the musculature or in the membrane to where now they can escape and go through it. Yep.
Isn't there like only a hole there though?
No,
Inguinal?
there shouldn't be.
Oh.
These are not a huge deal unless they're strangulated. Okay. So like if they end up twisting in there, or like it's tight enough in that hole to where it's cutting off blood flow and all that stuff, like now it's a problem. Okay. Yeah, right. Like, yeah, because, yep, it's just like a tourniquet. Exactly. So anything in your body, right? My skin, my heart, my lung, my intestine, my testicle, like everything needs blood flow, right? So if I cut the blood flow off to it, doesn't get blood flow, then it's going to become necrotic, and then it can die, and then it can give me sepsis and do all the things.
So there it says that he was able to push it back in, but now he's not able to.
Mhm.
Does that mean that more, so with that one, it'd probably be the intestine? The intestine's either gotten twisted or it's just stuck?
Yeah, it's kind of hard to tell, right? Because like sometimes, like if people get these a lot and they haven't gotten it corrected, right? They're like, yeah, I get this all the time. I can usually, like, my doctor showed me how to push it back in, but like now I can't get it back in. So either A, something has changed, maybe it's more than what it normally is. For whatever reason, you just can't get it back in this time, right? Maybe it twisted. Yep. And so, like for these, like usually they need to be surgically corrected, right? They need to go back in there, like find the tear, either put a mesh over it or repair the tear. Yeah. I don't know. He's got like a weird triangle trifecta going on.
Oh, that's like that all the places you get a hernia.
Yeah, like those are the common ones.
Would the femoral be more dangerous because of the patient?
I mean, maybe, but
Okay.
My little brother lived with that femoral wound for years. He just had it fixed for probably about 5 years.
okay, renal colic. So kidney stone. Anybody ever had a kidney stone? Any males
Working on it.
working on it? Yeah, getting
A
there.
lot of monsters.
Okay. I've never had one, knock on wood. I don't want one. But these are not fun to deal with. So when you look at these things under a microscope, they're actually barbed. Okay. So like when it's coming down your ureter, it's like literally just catching in there like a fish hook and just shredding all the way down, all the way down, all the way down. Okay. Yep. Same like in your urethra, right? Like it's barbed, it's shredding tissue all the way down. Okay. Believe it or not, I don't know. Like I said, I've never had one. You maybe could be a good test for us. So they say that a kidney stone is the male equivalent of giving birth for a female as far as pain goes. Maybe, maybe not. I don't know. Okay. But I'll tell you this, they hurt. So usually you're going to find severe flank pain. And it just kind of depends, right? Like depending on where it's at, like if it's like right up here outside of my kidney, sure, flank. But if I've pushed it halfway down, like I'm probably going to have pain all over down here, right? So I would say for the most part, flank to crotch is where you're looking, okay? And it's colic, right? It'll be colicky because it's trying to shove that stone down, right? It's going to squeeze and spasm, okay? What was your question?
Do you get those surgically removed instead of pissing them out, or do you just have to ride the lathe?
If they're under 10 millimeters, you typically will ride it. It just kind of depends. Like usually like 5 or so or less, they'll let you ride it out. 5 to 10, you might do like some lithotripsy. Over 10, like you got to go get it cut out. So I guess if you had to get one, choose one that's 10 so you don't have to piss it out.
I was gonna say I won't piss forever.
Yep. Nausea, vomiting is common, like severe pain. I'll tell you, like I've picked up tons of old people, right? Like ranchers, like dudes that'll break their pelvis and like walk to the hospital, and you know when they're having a kidney stone because that's the one time they're going to call. It's the one time they'll doubled over. It's the one time they can't walk. It's the one time they can't get there. Yeah. Oh, for sure. Yep. Yep. So like if you lodge the stone in your ureter and then let it go for a while, that's causing an obstruction upflow, right? So now all of a sudden you're just hanging urine in your kidney that's just sitting there. So you can get like a pyelonephritis, like kidney infection, that can make you septic as well. God forbid you actually like ruptured a ureter or something like that. Yeah. Okay. Keep a high index of suspicion with abdominal pain for cardiac involvement. So heartburn, right? Like I got heartburn, like don't get rid of their heart. Okay. Epigastric pain. Don't get me wrong, like lower abdominal pain, sure, like that doesn't really make a lot of sense. But again, like remember, like 1% of the time you're gonna have a zebra in there, okay? But especially when it comes to epigastric pain or like upper pain or like I've got this heartburn, same, like here's another good one, right? Like I just ate this big old cheeseburger and blah, blah, blah. And you're like, yeah, gallbladder. Like certainly could be a heart attack because I've been eating that shit for the last 20 years, right? Okay, so keep that in mind. Repro. So any female of childbearing age should be considered an ectopic until proven otherwise. What is childbearing age?
Period until menopause.
Puberty?
Yeah.
Okay.
Happens younger and younger nowadays.
Yeah, right. Like there's documented cases of girls like
If they have
6, 7, 8 years old getting pregnant.
Until.
Okay. There's documented cases of like,
A 5-year-old.
right, like older people getting pregnant, right? Like people you would expect have gone through menopause already or something of that nature. Okay. So like keep that in mind. Okay. So ectopic is when you fertilize an embryo anywhere outside of the uterus. Okay. Most common is going to be in the fallopian tube. You can have them intra-abdominally. So like, remember your fallopian tube and your uterus are not actually directly connected, right? There's a little space there. So it's theoretically possible, and there are cases of it where that egg actually comes out and then implants outside in your abdomen. Okay. Rupture can cause life-threatening internal bleeding. So this is a big one. It's big for maternal mortality, the word I'm trying to think of. And then also just kind of keep in mind too, like kind of going back to where we are nowadays, but like you can't reimplant an ectopic pregnancy. Like it's a non-viable pregnancy. Okay.
Some governor somewhere disagrees with you, Mike.
Yeah, well, he's over on the other side of the country. And he's an idiot.
Yeah.
Okay, so assess, do like you would with any other patient, right? Do a good assessment, get a good history, get your vitals, right? Treat signs and symptoms of shock if they have shock. Protect yourself from vomiting. Like you don't want that in your face. Keep in mind your geriatric elderly patients, right? They have a decreased ability to perceive pain. They can't really compensate very well. They're usually on like a bucket load of medications. That's going to alter how they compensate and stuff. Do you guys have any questions about the tum-tum? No? Okay. Do a quick potty break, and then
Okay, quick shake out.
Mikey's going to take you through psych. Because he's
great.
Yeah. He's the
Are
psych
you being a
whisperer.
sarcastic asshole right now?
No.
Why are you?
Is
I'm
the
doing
reason you
good.
didn't let him teach us about the inside and the organs because this man wanted to visit them to stop the bleeding?
Ask him how he heard that story.
I don't even think I was here for this story.
No,
I
dude.
wasn't even here.
Well, Britt was the medic. Do you remember? You remember the whole that Dave Ellis class of EMTs that was doing the manual?
Well, to be fair, it wasn't him.
It wasn't who?
Dave.
No, it was Christina. Yeah. So this is Michael Hoover. Brittany Hoover was the medic that was riding that day.
When you told her?
Yeah.
That's hilarious.
Yeah.
And so this man comes up to you and he's like, oh my God, you're never going to believe this story.
Yeah, one day he's like, hey, dude, yeah, guess what? Haha, fucking dumb EMTs wanted to do this. And I'm like, yeah, that's crazy. That sounds terrible.
How long is
Stupid.
it before you told him it was you?
Not long.
I actually remember telling you, like, yeah, you're right, bro. Like, take one hand and it goes in the back hole.
Yeah,
Take
yeah.
The other one, and then your knees, and you can.
You can just do the whole trifecta. I'm good. I'm still streaming with
You should, I mean,
the
I
folks from.
checked it. Probably should have checked it.
How do you check it? What is this?
You took my orange?
That's whatever I got. I grabbed two. I got one orange and one green. One of the good greens. One.
Okay.
The orange are better than the good greens.
Not.
Yeah. I think we're good. Maybe.
Pink.
I don't like.
And you haven't been sharing?
I don't like.
Okay, we're good.
I gave you most of the.
Yeah.
I gave you all the reds. I gave you
All
most
of
of the
Don't want.
I gave you most of the dark greens.
Yeah, why?
Brick is going on here, dude.
I also just
I
wanted
like
to try them.
orange and lemon
That's fair.
and lime. And citrus.
I think there's some watermelon.
Is it? I love watermelon.
I like green.
I don't like artificial watermelon usually.
Oh my God, it's already 7.
Yeah, it is. Sorry, guys.
Let's
Way before it was 30.
I get up at like 2:30 to 3,
Oh, that's pretty.
and then I get home at like,
But I had my mom's trouble at it.
on nights like this, 10, 10:15. And then I take care of
Alright.
the dog and try to microwave myself.
Okay.
It's one of those 4 trains. It's like
Yeah.
high top, like the one we had. It's pretty badass.
Yeah.
I raced my son down the freeway at like 105. And then I was like, hey, you realize that Mustang's
Try to
fine?
sleep
She goes,
Mondays and Wednesdays,
I was like,
but
you better sleep.
this
I
Wednesday
still,
I was like,
and then meanwhile, I stopped the car. And
oh, we're just not.
I got back on the freeway. It was high.
Yeah, there's no nicotine, no
And I did well when I drank.
I was like, oh, I looked up. And
Like, it's
I
nice.
was like,
It goes away, but. Plus with gas, just that it is.
Okay. Is every,
You had to be out
No,
here.
not
and they were
everybody.
doing- and
Oh,
then-
no.
When the both burn out, one is worse than the other.
Try the raspberry ones.
No, not raspberry.
There's a blue raspberry. I love
I looked online and they only had 4 things.
you want me to talk smack about my ability to deal with psychs? He said, were you talking smack about my ability to deal with
No,
psychs?
it'd be legit.
I have the
I'm good with psychs?
I did those ones because I have an apple.
Interesting.
Don't think you are.
It depends. I think it depends on the circumstance.
Besides our, besides our one, besides our one.
Yeah.
Kind of rains.
That one does.
You like the
Bacon.
Caesar
Can I have another one of the tropicals?
oh, there's still a call.
What does that mean?
Strangle my child.
Who's on
Who's
call?
on?
I would probably-
Who's on call?
I'm on call right now.
Oh, are you?
I have a key for you.
And then,
You work tomorrow?
Eric will be on call after me.
I don't want to.
There's only been one girl that's talked to you.
I'll bring it over to you.
Wow,
that
Which
was
one?
I'm sorry. I
a
didn't-
wild
Huh?
throw.
Which one was that?
Sports ball.
One of them.
Sports call.
No, not at all. My
You can
sports
talk
were
some people down.
Oh.
Jacqueline and.
Yeah,
I don't remember her.
Wasn't that Redford thing?
Oh, yeah, she did not like me. Yeah, she hated me. You're right, dude. She was pissed.
Thank you, Megan.
I am, yeah, I can talk
I was
to
like,
her.
well, Mike, you can't talk to her. No one's.
Yeah, she was pissed.
Who hated you? What?
I had a patient that really did not like me.
What did you do?
Nothing, actually. I was very kind and cordial.
Why'd she hate you?
She was very intoxicated and about to catch a DUI.
Why did she hate you?
I don't know. That's a good question.
She didn't try to fill you up?
No, she was young. This kid was like 17, 16.
You tell her what you taught your children about cops?
I did not.
That would have been bonding, a bonding moment.
No, I don't think anything would have bonded us. She literally tried to snatch the knife out of my pocket and stab me. And she tried to stab herself with Marcus too, so yeah. She was a handful. Okay. Everybody here or are we missing one? Everybody's here? Okay, we're gonna punch through this real quick since it's already about 7 o'clock. So we're gonna go through behavioral, psychiatric. Damn, dude, you can't put me under pressure like that anymore. That's too much pressure. Please don't do that again.
You can hide that.
He just hangs up on you.
Okay, so the rates of suicidal ideation are growing. And this puts us in a gray legal area as well. Here in Nevada, the only people that can initiate a legal 2000, which is the right to take somebody else's right, is law enforcement or a physician. EMS cannot do it, right? As we learned earlier in the class, if someone's A&O times 4, they have a right to make their own medical decisions. So I'll pose you the question: if someone's A&O times 4, but they're suicidal, are they in their right state of mind?
No.
So do you think you have a legal right to take somebody's right away at that point and forcibly take them to a hospital?
No, that's why you call Smith.
Okay.
Are they trying to grab your knife out of your pocket and stab you?
Yeah, and this is where we get in kind of a gray area, because all across the country there's been different rulings. And now you're seeing in major metropolitan areas, they're no longer sending cops to these calls. They're sending EMS and social workers. Also be aware that somebody just being crazy, or like if you say, oh, they're just crazy, like that's a diagnosis of exclusion, right? Like, because there could be a million things causing somebody to act altered or with erratic behavior that is not necessarily, still out?
Come on, man.
All right, fix it for me. That is not necessarily, that's more of a medical problem than a behavioral problem, but we're going to punch through this real quick, sorry. Okay, our objectives today, we're going to define what a behavioral emergency is, identify special considerations, and basically a behavioral emergency is going to be anything that falls outside of what is standard or normal, okay? So right now, if we're in this room, if I start dropping like 5 F-bombs, is that going to be considered a behavioral emergency? Probably not, right? It's going to be pretty typical. Right? That's a behavioral emergency. Okay. Identify what vitals are associated with excited delirium. I will tell you, as of last year, excited delirium was taken out of the DSM-5, which is the manual that covers mental health stuff, as an actual diagnosis. Why? Because law enforcement was overusing this and saying, oh, they're excited delirium. A couple people died. So now they've taken it out, and the more widely accepted term now is like a psychiatric emergency. But excited delirium, just because they took it out doesn't mean it's not a thing. It very much is a thing that we need to be aware of, because you're going to encounter people with either like a psychotic episode or excited delirium quite often. Okay, behavioral emergency, we just talked about manner in which a person acts or performs. Behavior within a given situation that is unacceptable or intolerable to patient's family, or community. Okay, different cultures act differently. I come from a Hispanic family. When they gather, I would call it a behavioral emergency, because it's 4 a.m. and we're partying over my niece's. My niece is like, whatever, turned 3, and like they're busting out the piñata at midnight. Like, nah, bro. Okay, full patient assessments. Again, we're not just dismissing people because they have suicidal ideation or they're acting crazy, right? Full patient assessments, because you never know what the underlying cause could be. In fact, I just had a young man whip my ass in the back of an ambulance that was acting like it would have just been a behavioral emergency. Wasn't, right? Underlying conditions leads to something else. So do yourself and your patients a favor. Don't dismiss them, and do some real digging for what could be a life-threatening condition to them.
What do you mean he whipped you? What happened?
He was strong as piss, and he was outside of his normal mind, and he was like literally almost picking me up with his arm.
What was your
He said sorry.
Yeah, did he? Dude, this kid whooped my ass. What's that?
What was your differential?
What was my differential? I was out of differentials at the end of it, but I had kind of assured that all the life threats were taken care of, but I did not know what was going on with him at the end of it. But he's fucking strong.
He's so sorry.
It's a good question. I don't know. I don't have the full follow-up on it.
Okay.
If I had the full follow-up, I would say. Okay, so why are we doing a full assessment? Well, we just talked about it, right? Different things can cause different behavioral patterns, okay? And if we're just calling somebody crazy, we're going to miss something important. Okay? All of these are causes of behavioral emergencies. Toxicology is a big one that you should keep in mind, right? Methamphetamine abuse, alcohol abuse, alcohol withdrawals, seizures, brain tumors. A lot of things can cause, sorry, I'll get out of the way, or I don't know. A lot of things can cause people to act erratically or have a behavioral emergency. Hypoglycemia is another really big one. Temperature changes. People who are like really hyperthermic can act erratic. So our behavior is controlled by neurotransmitters inside the brain. The impulse moves across the nervous system, and that's basically how that's how your whole system works, right? Even the way you like to move a finger, that's how the system works. Neurotransmitters or lack thereof have been connected in depression and other psychiatric disorders. Does anybody know like what one of the most widely prescribed drugs in the United States is? Yeah, like it's your SSRIs, right? The depression is like a rampant condition across the United States right now, and it's just getting worse. And we're just prescribing more and more of these drugs. Okay, some of these are going to come from like legitimate mental disorders, right? 1 in 5 have a mental illness, whether that be schizophrenia, depression, bipolar disorder. The big things to realize with like schizophrenia, especially nowadays, like most of the time you're not going to develop that like late into your adulthood. Most of the time you're going to develop schizophrenia early. Can anyone tell me the demographic that is most likely to develop a psychiatric disorder from marijuana use today? Young men. Young men are developing psychiatric disorders at a way more alarming rate now with the way THC is than they were 20, 30 years ago.
Because they had a bunch of different random shit.
And it's ultra concentrated now.
Aren't young black men more susceptible to like schizophrenia?
That's a good question. I don't know. Mike, do you know that answer?
I don't think specifically.
I don't think it's like specific to African Americans, but I mean, it might, like, maybe it's more prevalent in a certain race than others.
Yeah. I don't know.
It's from the mom's genetic, and it like skips a generation. I only know because my aunt has it. She's got triplets, so it has.
Oh, wow. Yeah. Yeah. Schizophrenia can be managed really well, but oftentimes what we will encounter is people who, for whatever reason, stop being compliant on their meds, and now, like, they've spiraled, right? Really sad. Humboldt just had a case of a young schizophrenic girl that was hit on the highway. Stuff when they don't have the ability to make rational decisions, they're not going to make rational decisions.
It looks like a negative feedback loop too.
Mm-hmm. It does, and truly, at EMS, we are not geared up to care for these people in an adequate fashion. Like I was saying, someone breaks their arm, we know what to do, right? But what do you do as a paramedic when somebody is telling you they're suicidal, right? It's kind of hard. It's a hard thing to treat effectively for us. Normal reactions to stressful situations produce emotions. We're probably all pretty familiar with what those emotions are. Caring for patients with situational stress reactions can obviously be a stressor on ourselves as well. Like I was just saying, like, what do we do, right? When there's really not an easy solution, right? You're having chest pain, I'll give you some aspirin. You broke your arm, I'll give you some pain meds. I'll reduce it and try to get a pulse back or whatever. But these are not like, okay, we move quick kind of calls. So the first thing, like, you got to make sure that you're staying safe because these are dynamic. But just think about if you were in that situation, and we've all had a moment of despair, right? A moment where you felt really low, where you just like felt like the world was caving in on you. What would you expect out of someone that was coming to help you then? And it's hard because these calls are not, it's not the lights and sirens and the flash and, we're doing cool shit. These are really the ones where EMS providers don't like to run them because they don't feel like
they don't feel like it's a good use of their skill, and that's absolutely wrong, right? These people deserve the best out of us just as much as anyone else that we serve. So don't rush it. Take your time. When you're talking to them, like, don't listen to respond, but listen to digest. Listen to, like, try to build a connection. And that's the one thing that I will say from personal experience is, like, when you're treating somebody in a behavioral emergency, if you can strive to make a connection with them and build their trust, you can serve them a lot better than just like, I've given you 5 minutes, now I'm going to give you 500 of ketamine in the arm and drag you out of the room, right? Like, no, take the time to build that relationship, build that trust. And it's hard to do, to talk to somebody when you don't have a clear answer for them.
Maybe won't try to stab you.
Maybe.
Drive an ambulance.
You never know how it goes. Okay, acute psychosis. This is going to be kind of like your excited delirium, but excited delirium, it veers more into drug use, but it's a severe break in the patient's ability to process information and interact with their environments. A lot of times this is associated with schizophrenia and bipolar disorder. The big thing you're going to see is when they are not compliant on their meds. Symptoms are going to be hallucinations, delusions, catatonia, thought disorder. What do you think if someone's in an acute psychosis? What do you think their vitals are going to look like? Elevated, right? Because they're going to be fucking worked up. They're going to think that something's coming after them, or right. Think about having hallucinations. Like, they're going to be worked up. Their temperature might be elevated. Their blood pressure, their heart rate. Do you think these people are going to be easy to reason with and level with? Okay. What if you come in all hot and heavy, right? Like kicking the door down. Do you think that's going to help the situation? No. Yeah, 100%, right? You're going to elevate them more. But if you can come in,
probably going to whoop your ass.
Yeah, come in with a level of calmness to you, right? All right, withdrawing, not communicating, bizarre, threatening behavior, wish to harm themselves or others. That's all like super, super common. Honestly, I haven't had a lot of people who want to harm others. Most of it is people who want to harm themselves. Mike, have you had a lot of people that want to hurt other people? Not really, right? It's all self-induced. Okay, go slow, make eye contact. You know, the easiest way to make somebody think that you actually give a shit is like to give a shit, you know, actually care about the person in front of you. It'll help you communicate with these people.
Bro, I thought you were gonna like throw some huge trick out there.
No. I mean, you can ask Marcus, man. When it comes to psychs, I have a soft spot, so I really take the time to, like, you know, give them the best, right? Give them a good chance.
So what if they keep trying to hurt you?
I've only had one that has ever tried to grab a knife from me.
But what about the guy that just tried to fight you?
Oh, he was not suicidal. No, he was
Oh.
like, when we talk about, right, don't just say they're crazy or they're just whatever. Like, he had an underlying medical condition that caused his altered state of mentation. Okay. And that's why we have to rule out all the other shit before we can say, no, they're just crazy. No. Okay, is their blood sugar good? Do they have a TBI? Do they have a tox on board? Are they withdrawing? Do they have like a, you know, yeah, like, you know, are they in and out of status seizures? Now they're in a psychosis. Like, we have to rule all that shit out before you just say, like, no, someone's just having a behavioral emergency or they're just a psych. Okay, suicide is the 10th leading cause of death in the U.S. and it's substantially higher for first responders. Alarming levels in combat veterans, seniors, and the senior citizen population. Potential or attempted suicide. Obviously, anyone that has like chronic depression or depression is at a higher level. Recent emotional trauma. The big thing that, does anyone know what the demographic is that commits to suicide the most?
15 to 25 and then over 40.
15 to 25, actually.
I want to say
sometimes younger.
I want to say it's like older white males is actually like your demographic that commits suicide the most. If I might be mistaken, I'm not sure. Drug and alcohol abuse as well. The big one here is, does the patient have a plan? So we know now that if somebody has a plan and has really articulated what they're going to do, their chances of going through with it are way higher. So if you said, hey, do you have a plan? And I said, yeah, I'm gonna jump on the railroad tracks, right? That is different than me saying like, yeah, I'm gonna wait till my kids go to school, and then I'm gonna take my truck and I'm gonna drive up to Lewis Canyon and I'm gonna blow my brains out. If someone give you a detailed plan like that, you better fucking believe them.
Yeah.
Because they have thought this through, they have the details laid out, and they are going to they are on the verge of going through with it. So you kind of have to learn to delineate. You have to take everybody serious, right? But you have to kind of delineate between like, okay, maybe not so credible to like, hey, this is really credible, we need to intervene. Previous attempts. And then the last one that's also really big is like a sudden improvement from depression. That's another big factor that you need to cue in on, right? And this is like maybe more for each other that you're around every day, and less for your patients, right? Because the odds are you're not going to know if your patient has a sudden improvement in mood. That's more of a key factor for each other.
Isn't at that point you would rely more on like family members and stuff like that, right?
You would, yeah. So if they said like, hey, he was been down in the dumps and now he's happy and he's giving his stuff away and he's like, yeah, like big factor, right? Big clue in.
But you don't normally see that, right? Because a lot of times I feel like the family is uneducated to the point where they wouldn't recognize that as a symptom of suicide.
Yeah, there's been a lot of campaigns out there now, though. There's been a lot of mental health campaigns. So this has been a hot topic that's been kind of brewing for a while, and like people are getting more and more educated. Even in our region, we have a substantial amount of like symposiums and things like that are happening that are cluing the right people in on this.
But it's also like I don't know what's going on. Like they've been happy. Like
yeah.
Like they're
So
turning their
like
life around.
post.
Yeah.
Okay.
Yep.
Post attempt.
So we're gonna talk about aggressive or hostile patients. First things first, right? Like you need to make sure that your scene is safe. Take what dispatch tells you. That is not always gospel though, right? Because they're receiving information. Sometimes they're receiving third-hand or third-party information. So take that with a grain of salt. When you come on a scene, listen to your gut. I will tell you, I rolled up on a scene one time and it was a standard carbon monoxide call. And when we got there, every light was off, every door was locked, and something was just off, right? Not like any other standard carbon monoxide call we've ever been on. My partner, like 3 minutes later, was literally like, hey, this is a suicide. And like this, we flipped the switch, but you got to kind of listen to your gut and cue in to what would be normal and what wouldn't be normal. Like what would you expect versus what is happening. Information from your neighbors, family, or bystanders. The big one's going to be for us, especially if we have a bit of a warning going into this, is going to be what is the sheriff's office telling you? Because the sheriff's office, if you have an aggressive or hostile patient, will be there before you're there. Like you're not gonna make entry onto a scene without them clearing it for you. So they'll give you a pretty good background before you go into it. Patient's body language, I mean, I think we can all kind of tell, if someone has like a bladed stance, if they start to like puff up a little bit. For me, my threshold for that is pretty low. Why? Because I'm a wimp. I'm not a fighter. I'm not even that much of a lover. I'm more of a napper personally. So my threshold is pretty low. Like someone like Andrew that I watched, do CPR with the palm of his hand and crush the whole thing in. Like I'm sure his threshold is a lot higher. Not mine. I'm good. I'm not built for it anymore. I'm old.
Bodyguard.
Yeah. Yeah, but just be mindful, right? Listen to your gut. Watch their body language. Watch their tone, the way they move, the way they position themselves. Like those are all clues and tells that what is yet to come, right? They'll tell you what they're going to do before they do it. You just have to pay attention to them. Anytime you're in a home, this is a big one. Like ensure you have an escape route. I mean, that's like basic 101, right? When you go inside of a house, like never have your back to where you can't get out, and have that plan in the back of your mind, right? And like, if you have somebody like this, make sure you have the cops nearby. And if the cops start to wander, like, hey, come back, right? You have a vest and a gun for a reason. I don't. I've seen your pay scale. It's way more than what our EMTs make. No, you can be in here, bro. You can be in here. Obviously, don't threaten the patient. Like, even if you're going to go hands-on with them and you have made that decision as a collective unit that you're going to go hands-on and take somebody's right away, don't threaten them with it. You can tell them, say, hey, we don't have a choice. They've decided that they're going to initiate a legal 2000 on you, or the doctor has decided they're going to initiate a legal 2000 on you. You're going to the hospital with us. One way or the other, don't threaten them, but communicate. Stay alert for weapons. Now, I would ask you, when you look at somebody, what's the 2 things they can hurt you with? Like just right now, it's these, right? Because guess what? I can't shoot you with my toe, right? I can't stab you with my toe, you know? If they're going to do something, it's going to be with these hands, and this is what you should keep your eyes on. Reasonable force. We don't have any cops in this class, but this was a good debate in the last class we had. So reasonable force is the force necessary to keep a patient from injuring self or others. Okay? This is what you have to be able to articulate in a court of law. That means if they ever put you on the stand and say, we don't believe that you used reasonable force, you have to be able to defend that you didn't go excessively over what you actually had to protect yourself and this patient, right? Because if we're using force, we're also doing it to protect the patient, okay? So it's determined by the patient's size and strength, their type of behavior, their mental status, and the available methods of restraint. If you ride with a paramedic, that 99.99% of the time is going to be chemical. We're going to put them to sleep with drugs. That is the safest method of restraint, as long as you're not careless, right? Because every drug has a side effect. For you guys, if you don't have a paramedic, that might be physical. Now, does that mean if Steven's going crazy, am I going to expect Lakin to restrain him alone? Absolutely not, right? That is an unsafe scene. That's not a tenable situation. Like, we're not doing that. So we're going to wait till we have the right amount of people and law enforcement. We're never going to cross the threshold into putting our safety at risk. Now, if there's 4 Andrews and I'm acting up or not acting up, right, but having a behavioral emergency, that's probably pretty reasonable that they now probably have a duty to intervene. Okay. And does that mean they can just beat the crap out of me? No, it's reasonable force, enough to get me in a safe restrained position. He walks through the door. I'm not doing nothing. You can call it a night for me. I'm done.
He is going whether he wants to or not.
Oh, yeah. Okay. We're going to consider restraints if the patient is a danger to themselves or others. Patients need to be monitored every 5 minutes. Year after year, we see that EMS actually kills people, and law enforcement actually, while they are restrained. This is a massive, massive, massive point of contention in EMS today. It's led to massive lawsuits, and you're not getting your license pulled. You're doing time in prison now, okay? So when we're talking about restraining people, it's a big deal, so we need to do it appropriately.
You can tell them what you did, what you had to do.
What I had to do? Oh, I gave him a fuck ton of drugs. I gave him like 10 of Versed, and then they had to give him even more, right? Like, I chemically restrained, and that was it was too, right? It was for his safety, but it was for our safety too, right? I got this young buck who's like a lot more spry than me, and he's letting me know it, right? Like, I got nothing left. And also, like, he's in distress, right? So I need to make sure that he's going to be safe. So we do chemical restraints. All right. Cardinal rules every 5 minutes. Just so you know, this is getting placed into law. If a patient or an inmate is placed in a restraint chair, by law, EMS must be present and vitals must be taken every 5 minutes. This is a statute that is passed for law enforcement, okay, because of the amount of issues that we've had. One person for each limb if you can. If you can have more, then do more. And we will never, ever, 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 no matter what, hog tie a patient face down, because you can kill them like that. And we have killed several people like that, and you will go to prison for it. So we're going to do restraints on the limbs. If they get excessive, we'll do a spit hood over the face if they're spitting on people. And they are going to be in the supine, prone. Damn, supine. Yeah, I'm losing it. In the supine position or semi-Fowler's position, never down on their face, never hog tied. This is a big, big no-no.
Not the best.
Hug yourself?
Yeah.
It's not a straight jacket.
So they have a wrap over at the sheriff's office now. We don't use those in the field. Just because we can't like safely transport them that way. What ours is going to be like these Velcro straps. And generally what I like to do is like one here, and then both the legs. And then if you have somebody that's really rowdy, you can like tie a sheet around their legs too, kind of take away their leverage points. I guess if you think about it right, you don't want them to be able to plant and buck on you in any way. So if you can take away their leverage points, that's the best way to do it. And while you're doing all this, like treat them humanely. If think about it this way, even if you don't have empathy for people, even if you don't care, if you're just like, this is wasting my time, like whatever, that's on you, right? If you'd be concerned about what the body cam would look like in a court of law, if that's the only thing that keeps you from acting like a dickhead, that's fine. But think about that. If this goes to court and there's body cams everywhere, what are you going to look like to a jury that's watching it? Okay? If you're communicating and being, empathetic and professional, that looks a lot different than yelling at somebody and, shoving their face into the gurney. There's a time to shove a face in a gurney. I'm not saying there's not. But, right, like think about what you're going to look like in a court of law. All right, excited delirium is usually going to be drug induced. It is life-threatening, and it attacks their cardiovascular and causes massive metabolic stress. A lot of the times we're going to see this from things like PCP, methamphetamines. I'm assuming you could also get it from acid, cocaine. Like the one we see the most around here is methamphetamines.
Are you just skipping over those videos on purpose?
Dude, I didn't know there were videos.
I was wondering what these were too. I'm like, oh, that's weird. It's just a blank slide.
Yeah, like I don't know.
So, press escape.
Deletes the whole slideshow.
It should take you to a link.
The other ones had like a link.
It's just a blank slide.
Maybe
It's
you
okay.
just took them out. Should be a video.
No, I'm sorry. I'm not trying to skip over these. I don't know what it is. Okay. This kind of goes out the window for us, but in a testing situation, right? Take them to the most appropriate facility. We don't have a choice. We're going to take them here. Big cities have psych hospitals that they can go to. Our closest psych hospital is now Elko. That doesn't mean that we can bypass Battle Mountain General and go all the way to Elko with a psych. Okay?
Would you call for that?
No.
Or you just show up at the hospital and they tell you?
Yeah, I would take them here first because they have like a psych ward up there, right? But it's not like a true like psych facility. They have like a level, but it'd be the same as like taking someone with an appy up there, like for general surgeon. Like it doesn't constitute a bypass. Not legally anyway. Okay, this is one of the sections that you should absolutely pay attention because this is like the gray area we live in all the time. Like I like to say, we're always teetering between patient abandonment and like kidnapping in this field. Refusals and restraints cause significant medical legal issues. If you have any questions or are like on the fence about anything, call your supervisor or call medical direction. Right, on-call medical direction can bail you out of a lot of this stuff. Laws typically allow providers to treat and transport patients against their will if a danger to themselves or others. We in Nevada don't have the legal authority to legal anybody. A legal 2000 must be implemented by law enforcement or a physician. Okay, so this is an even more gray area for us. Yeah, like mind your P's and Q's in the back of these ambulances. If you feel like you're in some kind of danger, then ask law enforcement to ride with you, and then they can have their body cams on. And you can always do that, especially here. They're way willing, especially during election season, they're way willing to do whatever we want. So, yeah. This is a big one. This is actually a policy we have here on actual psych transfers from like here to Reno. If you have a same, if it's doable and you can have a same-sex provider ride with that patient, do that. And I mean, we're just like, in the next 5 years, you're going to see EMS wear body cameras. It's already coming. If they're aggressive, have law enforcement accompany you. We don't ever take anybody in handcuffs without law enforcement, ever. Right? Once those cuffs are on, they are the custodian over those patients. Like, they make the decisions for them. Like, they've lost their rights. So if they're in cuffs, the cops come with us. Okay, any questions? So what I'm going to do now is, because we came through this kind of quick, I want you guys to look up a case when you have your own time. Damn, what was that ketamine kid's name?
Colorado.
Yeah.
Ketamine,
Just look up Ketamine, Colorado.
Yeah, just look up Elijah. Yeah, for sure. Elijah McClain. So if you have time, look up the Elijah McClain case, and you will see a prime example of somebody that did not need to die, but it was negligence on EMS's part. And you will see why behavioral emergencies should be taken seriously. Yeah. Elijah McClain, Colorado.
I did that, had that 90 tag. Law enforcement.
Yeah, well, that was another recent case where this kid, they got called for anxiety, things went sideways, and even before the kid died, law enforcement was like, I don't know, they said something about, man, I hope this kid doesn't die, right? Like, ha ha ha, like fist bumped each other, kid ends up dying, everybody gets sued. Yeah, yeah. So we're to be patient advocates, right? Don't forget.
No.
Okay. All right, take a little break. See, it's 7:30. Do you guys want to punch through the next one, or you want to?
So I'm gonna leave this up
Want to
to you
go home?
guys. I think we could get through this next one by 8 o'clock. But if you guys are fried and done for the night, then not done.
It's okay if you're fried, dude. Right? You only have so much bandwidth. Or if you guys like, no, like we can muster it a little bit and punch through it and shave some off the back end.
How many slides the next one?
It's like 25.
20, yeah.
I think we should.
We've been up since 3 a.m.
Ooh, that's not terrible.
And we have to get back up. And we both have an hour plus drive home.
Yeah, we can.
Yeah.
Yeah, we can tackle the Saturday.
What time do you get up?
2:30.
No, I think we should tag out. Just saying.
I'm not for anything.
Okay, three people say tag out, I'm not gonna make people stay.
Yeah,
They
let's do it,
can't.
dude. No sweat. Good work.
Hey, so,
We'll call it a night. Everybody signed in?
Yeah, yeah, this is
Okay.
a group effort.
Appreciate it.
5 years.
I'm not worried about the drive home.
Yes, thank you for the shirts.
Oh, yeah.
Do you want us to wear
So
these
roll
on the
traffic.
along?
No,
Custom meeting and voices, right?
They said no?
they said no because they don't want, if we have to do CPR on the patient, you don't wanna have the family looking at what's on the back
27
of
to
them.
23.
Yeah, listen.
Not see
So
that?
when we hold on, time
That's
out. With these
hilarious.
shirts,
I did not see that.
don't wear them to your clinicals, please.
5 years.
It is funny. Yes, it is funny. You're wrong, like it is. But think about if you were a family member and right, like we're coding your kid right now, and you read the back of that.
Yeah, I just looked it up and I was like, oh, City of Aurora.
Oh.
That's usually where everything happens.
I didn't know what it said.
You should've put-
That's.
No, I would be able to wear a t-shirt.
Plus I heard you say it earlier too, so.
What if I just put a sticker?
That's fine.
Two for another space on the double SIC.
Where'd you guys get the?
Should've
I'm gonna wear a
said,
shirt that
Stop
says-
screaming, I'm scared too.
Yeah,
Yeah,
I'm
yeah,
getting one of those shirts.
yeah. I've been there.
I wore it.
Like the whole like calm down.
What you said?
My name, like,
Remember that saying?
That's what I said?
Remember?
No, I didn't remember that.
Oh,
That
no.
was like
Like
the
the first
greatest
week,
thing,
though.
yeah, it was like the first week.
And they put it on your shirt.
You were doing like a patient assessment
Oh.
up front.
No,
And you were like,
you
there's a
do
100% chance,
CPR. Yeah.
100% chance of doing
You guys
that.
actually made that a shirt? That's
About what?